Our next presentation is entitled Senior LifeCare, Observations from the AARP Foundation Ridesharing Study. Please welcome our presenters, Rebecca Ebert, Research Coordinator, USC's Keck School of Medicine, and Dr. Leslie Saxon, Executive Director, USC Center for Body Computing, and who has amazingly participated in virtually every presentation today. Dr. Saxon.
Yeah, this is where we've been the last year working on this stuff. So we're going to provide some preliminary results in what I think is a fantastic study, and I have to give great credit to Rebecca Ebert, who actually taught over 100 people over 70 to use an app. So anyone who's tried to teach their parents successfully. So as part of the study, which we're very proud to announce the preliminary results of. So we announced a year ago that AARP Foundation, funded by United Healthcare, had given us a $1 million grant to study ride sharing in senior people with chronic disease. But one aspect of healthcare outcomes in seniors is access to medical visits, and seniors don't have a hard time getting to medical visits. But what really predicts outcomes in seniors is social isolation. And the things that impact that are healthcare access, lack of access to transportation, and social interaction. So for us, the study, if it was going to be a study here, it had to be about tackling all of those, because a lot's taken away from people as they age, and it really is depressing, and it really does result in worse healthcare outcomes. And it also results in this hidden family dysfunction and costs, where the daughter is taking off work to take the parent. It creates a lot of dynamics that aren't comfortable for anyone. So we designed this study to provide unrestricted rides to seniors anywhere. And we also tracked their activity. Can you go back one? So before we get into the results of this, I just want to share a video from a patient of mine who I took care of for 15 years, and it was a real joy for me because he was such a joy. And he had been just an enormously active and important guy in the music industry for about 30 years, representing talent like Whitney Houston. And he's actually a friend of mine. My husband and I would go to supper clubs with him and listen to jazz musicians because he turned me on to a bunch of them. And we shared a love of music. So I just, as his health deteriorated and he started to become a patient of mine, he just had health event after health event, and it depleted his savings, and it depleted his enormous amount of freedom that he had as a person and joy. But he was a participant in the study, and I just want to show you a video of him, Ken Reynolds.
I never had any issues at 30, 40, 50, 60, 69, all the landmark birthdays where people have issues. But something happened at 70. Even though I'd been a senior citizen for, 15 years, I realized I'm a senior citizen. It's not so much I mind living alone, but thinking about at some point, I'm gonna have to give up my independence. And I think that's what bothers me more than anything else. I don't wanna drive at night. Driving in the daytime like this, it's so bright, the lines are blurred, everything is blurred to me. It is difficult asking friends for a ride because you feel like you're a burden. You feel like you're becoming a burden to your friends. I go to dialysis 3 times a week. I have eye doctor appointments, I have dentist appointments, I have appointments with the wellness center. So this transportation is such a welcome situation for me because I don't know that I could drive right now, and don't know what I would do right now. If something happens to me, when I stay in this house a couple of days by myself, I get withdrawn, just not just physically, but mentally too. I feel this urge and need to get out and be among people. It lifts my spirits. It makes me feel better. It makes me feel better about myself. I would say it's extremely important. I think what Keck, USC, AARP Foundation, United Healthcare, and Lyft are doing, it is so beneficial. It is keeping a person like myself in a mentally and healthy status. This is a very transitional point in our lives, and it provides us an opportunity to get out and be among the living and be among those that are doing things.
All right.
Hi, hello. Good afternoon. I'm Rebecca Ebert. I'm thrilled to be here. This is my first year as the research coordinator at the conference with the Center for Body Computing, and I'm thrilled to share with you these preliminary findings from our research study. So what we were doing is we were investigating the effect that unlimited and free on-demand ride-sharing services would have on older patients with chronic disease. So what does that mean? Unlimited was not just to medical appointments. It was those social visits as well, going to see family that they can't get to, going out and just getting out of the house. Like Ken said, he just would really feel stifled being forced to stay at home. So what were we measuring? We looked at ride technology adoption and use. So we were told by so many people who have tried to teach their parents Facebook and how to use a smartphone that it would be impossible to teach 150 older adults how to use this technology. So that's one thing we were looking at. We wanted to see how it would impact their activity levels, because we know that even minor increases in activity has long-term health benefits. And then we wanted to see how it would impact their social isolation and quality of life if it would change that. So the design of our study, we used wrist-worn activity sensors to measure activity, validated survey measures to measure social isolation, quality of life, aspects like that, and we used Lyft for our ride-sharing option. So the way the study worked is we brought in patients, we found them, we enrolled them. We threw a Fitbit on them for the whole study. The first 2 weeks were without rides. It allowed us to look at their baseline. We also had them do those surveys to see, what their headspace, what with their methods of transportation, what their how comfortable they were with the technology coming into the study. And then they had 3 months of ride access. Part of that initial enrollment period was also an intensive tech training where I actually sat down with each individual, some who didn't know an app from a text message, and I taught them how to use the service. This was for smartphone users. Those that weren't smartphone users, we did offer a call-in service so as not to exclude anybody based on income level or access to the technology. Our study staff was available to, patients need some support. We could answer any calls, and it's just that extra blanket that we provided if things go wrong. It took them a couple times, maybe a couple calls before they were comfortable using it. All right, now this is a map of our center. So you can see the red is where we're located, and this is the wide catchment area we were pulling patients from. Our patients came from so far away. If I actually included Bakersfield, which is currently our furthest patient, 113 miles away, the rest of those blue dots would just look like one giant dot. So these people are coming from over 100 miles away. They're coming from Ontario, over an hour away, Chino Hills, Lancaster, Thousand Oaks, because we have this specialty care here at Keck. All of our patients, all 150 were USC patients. They all had chronic conditions, being treated at Keck for their chronic disease. They were all over the age of 60, and they reported some form of a transportation barrier. And they were all able to handle the curb-to-curb service that Lyft provides. We had plenty of patients with the walkers who would slowly make it out to the curb, but that was totally acceptable, and those drivers would jump out and help them with the walker. So you can see here the wide variety of our patients. And with this, I'm just presenting on the first 74 participants. We just finished enrollment for the study. It's ongoing. These are the first 74 who completed the 3-month follow-up. Our average patient was about 71, but 57% were over the age of 70. And our oldest was actually 92. 66% were female, about half lived alone, and only 6% were employed full-time. So the majority were retired, they were on disability, or they were unable to work for other reasons. And while 96% had a high school diploma, which is significantly higher than what we see nationally, more than half of our patients, as you can see on the left, were making less than the national average for income annually, which is about $38,000. We had great support from our Keck clinics. We worked very closely with the different clinics, the different physicians there, the different clinic organizers, and they really helped get the word out. Helped build trust with these participants. 49%, so about half, were seeing a specialist in internal medicine, and about a quarter of those were seeing a cardiologist for cardiovascular disease. Now 26% were major surgery patients. They were coming back a lot for follow-ups or for more surgery. 13% of those are our transplant patients. And then we have plenty of frequent flyers getting cancer treatment. Seeing the ophthalmologist, they're not able to see when they drive, neurology, psychiatry, pain management, those meds just predict, we know what they do when you drive. All right, and this is a novice of, 57% were over 70. They were novice to their smartphones. Some had heard from their kids or had seen the cars. They were familiar with Uber and Lyft, but few had used it before, and we wanted to know why. So they didn't know how. They were unfamiliar with it. They were afraid, and they didn't know the drivers. So that was more of our education system, as we did want to, teach them not only how to use the technology, but teach them a little bit about Lyft. It's not a stranger driving you. It's actually a vetted person. We can track the rides, all of that. So when we looked at the ride data, we were thrilled to see that, in fact, you can teach somebody over 60 how to use a new technology, because 80% of our patients preferred the app. And altogether, those 74 people took 4,800 rides. So that's about one ride a day at $20 a ride. And the average ride was about 14 miles. Now, we love to see that our app users embraced it. They took more rides significantly than our concierge users. That's our call-in, our people who use the call-in service. The app users had more than double rides on average than our concierge users. And they took more social rides. So they weren't just going to their doctors. They were seeing their kids across town that they had trouble getting to. My one patient, she finished her chemotherapy, and she took her sister to Marengo Casino. And we had a couple just go to the beach for their anniversary. So 99% of the patients did use the ride service. And when polled after the study, 97% said that they were more comfortable using their smartphones after that intensive tech training and just using Lyft throughout. 90% reported that they would use the service again, use Lyft specifically, and 91% reported that it was easy to use. So I mentioned activity. We put these Fitbits on our patients, and we didn't know what we would find. We were very hopeful, but how does ride translate to activity? And we were thrilled to see that there was a 35% increase in total daily steps, which is how we measured activity levels. Now, this was a very sedentary population with about 2,000 steps on average. That's about a mile a day. And we increased that by 35%, or we saw an increase of that by 35% in this study. I just have a quick story, because this is one of my favorites. How do rides get you moving more? We had a 92-year-old. She was the oldest patient in the study. Her husband had just passed, and he was the primary transportation for her. And once she joined the study, she decided to join a women's group at the gym, and she was going 3 days a week because of this transportation study. So again, in our exit surveys, we asked patients, how did this impact your life? Because I'm on the phone all the time with these patients. I hear their great stories, but how do we measure that? We saw that 90% said it had a positive impact on their quality of life. So it really made their overall life, so many improvements. And then 68% said it was easier to get to their medical centers, get to their medical appointments. And 74% said that it increased their social visits. All right, so from this study, we're continuing to analyze our data, but right now we're thrilled to see that our patients did embrace the technology and started to use it frequently. And we saw that we had improved activity levels, again, by 35%. And we did see that it improved socialization, and it improved daily quality of life. So again, those three aspects of health care, outcomes in older adults, activity, being also crucial. But we improved their healthcare access, we improved their social isolation, and we improved their by providing them with transportation. Of course, there's always more work to do, and as we complete the data analysis, the next steps, will include putting this information up against a cost-benefit analysis to see how we can implement it long-term in the future on a more, national, global level. And now Dr. Saxon and I will take questions.
So we're joined by commentators. Great job, Rebecca. We are joined by commentators. Paul Irving, Chairman, Center for the Future of Aging, Milken Institute, and Dr. Paulo Narciso, Director, Social Entrepreneur in Residence Program, the AARP Foundation. Welcome to both of you.
Thank you.
So Paulo, maybe you could start, and Paul, just like you to kind of tell me what you think about the study, and Paul, how you think it could impact senior population.
Sure. I mean, obviously, there's a lot of the study that verifies a lot of things we know already about social isolation and the risk of social isolation in terms of impact to health, and the effects of transportation towards social isolation. So that was great. What I love about the study, though, was the way you combine both just ride sharing or getting rides for to go to the hospital or to go see medical visits, as well as to see what the actual increase in mobility was and in social isolation and connectivity. I think that's really, really important piece of this particular study. And I'm excited about the implications of this in terms of how we might be able to take what we've learned and be able to find a way to be able to sustain this and be able to support the large population of aging Americans today.
Paul, I just have to ask you, because I'll cut to the chase, because a lot of these people really, average 65-year-old, these pretty poor, a couple $1,000 a month, $2,000 to $3,000 coming in. It's about $400 a month if we do the math. We need a supplement of $400 a month for this benefit to change somebody. What does that work?
So I think maybe it's a $64,000 question, which is, and by the way, I wasn't surprised by, and I was happy to see the results. This, frankly, the only thing that surprised me was the percentage that preferred the app over the concierge approach. But as I often remind people, I think the average age was 70-ish. So the oldest baby boomer today, born in 1946, is 72, and we should remember that boomers invented the internet. So. So maybe it's no surprise that they're more technologically proficient and inclined than we give them credit for. So I think the big question is payment, right? The big question is whether it's a private pay or reimbursement, Medicare, Medicaid. Can we both make the case as a result of cost savings? And I think, I was saying earlier, maybe the next step is economic analysis. It would be great to see this in a longitudinal study that really measured the impact on chronic disease. Leslie, you're a cardiologist, and how office visits and frankly med compliance, et cetera, can affect
Missed
health.
medical appointments. I used to have to pick up my mother from downtown
Right.
to Santa Monica to take her to the doctor, because even if I called Uber for her, it was tough for her to. So she, it's almost like the people have to use the app, because the concierge doesn't really work, because the concierge service for us was they called us and we called the ride sharing. But for it to really.
So, I mean, look, my instinct, based on what I see, and again, none of it comes as a surprise. I think it's happy results. Is that if it in fact improves compliance, if it in fact creates additional access, if it reduces isolation and probably therefore we would hope reported loneliness, et cetera, that manifests in better conditions, potentially deferral or reduction in chronic disease, et cetera. We got to put numbers around that, and then without maybe a day after some interesting political activity in the U.S., I suppose we can make the case that those of us who believe in investment in public health need to be able to persuade those who may not be as politically inclined to persuade them that there's financial return by way of cost savings. So, and it makes sense to me that there would be.
Do you think, I'm curious if people think, there are a lot of people representing, so if you have an expensive drug, for instance, or you make an expensive medical device, and you knew that you could get adoption and uptake from a patient and get them to their medical appointments, it was $400 per patient. There could be a model that even a farmer, a device company, not to mention a hospital, would pay. I know, I think there's a good chance that we can win on this if anybody accept. It's a very subtle economic analysis, right? How many hours did a child have to take? It's hard to figure out what the economic model looks like exactly. I'm curious, David Baxter, does that $400 a month seem like a?
Well, I'm not going to commit to $400 a month, but
Yeah, free Lyft rides, because we can't take it away. It's heartbreaking.
yeah, exactly. But
We need a mic. Can we have a mic?
and Leslie, you know, I'm just a corporate seagull, so I have no execution authority whatsoever. But that point aside, you know, what I think is interesting, and I think the proposition that you're suggesting is, will our companies willing to make an investment to either enhance the value of their therapies, improve outcomes to the patients they're trying to serve, or broaden the adoption of the therapy? And I think the answer to that is yes. I mean, we spend a tremendous amount of money in market development. We've talked about spending $100 million in clinical evidence generation over the next 5 years. So I think conceptually, we're all trying to figure out what's the most efficient way to deploy our dollars to drive therapy adoption. And for us specifically at Baxter, and I was really interested on the comments from one of the earlier panels around reimbursement supporting ride sharing. We have a ton of patients who are on dialysis is our single biggest business. We have a lot of patients who are at home on therapy, but we have over a 20% dropout rate in the first 90 days. And some of that's because the therapy's hard. People have have comorbidities. They can't go see a doctor. They're in remote areas. They don't have access to medical care. There are a whole bunch of reasons that people don't stay on therapy. So as we think about the ecosystem needed to drive things like compliance on dialysis therapy, something like this is super intriguing because, as you know, people end up on dialysis because of things like diabetes and hypertension and cardiovascular disease. And managing diabetes, ESRD is really managing all of those comorbidities. So as we think about keeping patients on home therapy and keeping them on for the optimal amount of time, ensuring that they're being treated across their whole spectrum of diseases is super important. So will we think about this? Absolutely. Can I sign the check today? No, but we are one of the reasons we're excited to sign this partnership with you guys is to open up new ways of thinking about our businesses and how to develop these therapies and move ourselves from just a company that's delivering therapy to one that's really treating patients more holistically. And this is a really creative way to think about doing that. So I know that's a non-answer, but
That's a yes to me.
Hopefully that helps.
That's a yes. Janet, did you have a?
Here we go. I mentioned during our talk, here's another idea for revenue. The Chronic Care Act was passed. It gives flexibility, and CMS is writing the rule, right? It gives flexibility for Medicare Advantage patients to be paid for health-related, non-medical related services. So number one, some advocacy to make sure that they don't get prescriptive on us, right? And give us the list of 20 things that are covered and that aren't covered. But I wonder with the new CMMI, that's the Innovation Center at CMS, maybe there's a pilot here, or maybe Medicare Advantage plans could get together and look at funding something like this. So, and then if it works, you've got folks in the private sector that might consider it as the rules get implemented.
Great. Carol Peden, would you mind commenting on this? You've done a lot of this in England and otherwise, finding ways to increase total outcomes by things like this. Can we get a microphone to Dr. Peden?
I think this is such a great study because the evidence on loneliness is so powerful. So facilitating older people to be more involved, to get to these appointments, it's going to pay off. But you've got to have the models of care where you can measure it. And that's harder in a US system where there's more fragmentation than when you're taking, capitated costs for the whole population. So I think this is a great idea. I'd love to see it roll out more. I think the social benefits are huge, as well as the health benefits.
Any other?
So, well, we know Great Britain has just appointed, the PM just appointed a new Minister of Loneliness. So,
yeah.
so the folks across the pond are well ahead of us, as oftentimes is the case these days.
Yeah.
Go ahead, she's got more.
Quick comment, yeah. There was a study in the southwest of England that showed that if you looked at emergency medical admissions, I think for the over 75s to the ED, one of the factors was loneliness, and they may not have talked to anybody for a month. I mean, it's just incredible.
Yeah. But Leslie, I just want to double down on something you said earlier, because you kind of slipped it in, and that is when economic analysis is being done, it can't just be disease cost. It's got to be productivity losses and gains. If it's not fully loaded, the numbers are just not going to be compelling enough. So So what we need to make sure we understand is the impact on caregivers, the issues of absenteeism, presenteeism, et cetera, the costs of all that, which are a charge on overall economic growth. And I think oftentimes, as much as I love many of my friends who are health economists, they're kind of in a bubble, and they talk about disease costs and don't take fully into account the potential risks, costs, et cetera, of the these kind of peripheral issues that dramatically increase the overall cost of disease.
Yeah, and the crazy thing is, for the most indigent, say the Medi-Cal patient, there is a benefit. You can get a ride, right? The problem is, it's hell. It's like, anybody ever I used to live in San Francisco, and taking the shared shuttle to the airport, you don't want to shoot yourself. So these older, sick people need to get into a van, and it's a benefit. They can have it for free. They need to schedule it way ahead of time. They need to get into a van. It stops 5 times. It'll take them 5-6 hours to get there, and then often they miss the van, these vulnerable populations. So you're leaving your clinic at 5:30, and the lady's on the curb with no way to get home because she missed the van. So you're going in your wallet going, okay, or calling them. I mean, it's just, so I know that somewhere in these, the government's paying more. Actually, they're probably paying more than what this would cost, because there is a benefit for the most. There is a safety net, if you will, but it just doesn't work for anybody.
Yeah, just to add to it, I know we talked about loneliness, and but there's also and loneliness and social isolation are very much connected with each other. But the interesting thing, obviously, it's an older population that you did in the study, and there are initiatives by CMI, for instance, around being able to pay for these rides ultimately, hopefully soon. But what sometimes is often missed is the preventative aspect of it as well. When you're not chronically, is there a way for us to be able to tackle the issue of social isolation, which is just like smoking 15 cigarettes a day from a health perspective, to make it more preventative? And the second component of that is, we look at an older population, and we do have programs like Medicare, for instance, that handle an older population, but there is a gap between the 50-year-olds and the 65-year-olds before they're qualified for this, and social isolation impacts everyone. And so, obviously older people more, but anybody over 50, I think the number of people who are socially isolated are about 17% of the American population over 50 is socially isolated. And so we have to look at this much more than just a Medicare government program. We have to look at it and to see how we might be able to trickle this down, not only in age, but also to trickle it down in terms of income. Because people who are in poverty have difficulty accessing some of these particular services also.
Sure.
Yeah, it's amazing how little these people actually have in terms of income. I think that surprised us, because it was a largely Medicare population, but just very stretched, so they could never afford it themselves, likely. Sir.
I mean, I just add that this could be an intervention. I mean, that would require kind of different measurement or different study that could affect all kinds of social determinants of health and disparities that are really, kind of remarkable. We know about the zip codes analysis across cities in the United States, where people live on average 20 years difference, which is really quite extraordinary. A lot of that has to do with access to a whole series of products and services and opportunities, and not just health access. It's food, it's exercise, it's opportunity for learning, et cetera. So, this I suspect is an extraordinarily inexpensive intervention. I mean, I'm guessing, and obviously more research is needed, but that could be successful across a whole range of domains.
No, I mean, Rebecca had patients who finished chemotherapy and went to Moronga Casino, and you don't have to spend that much money if you walk around to 4 slots for 4 hours, But that was like just a huge thing.
Yeah, I mean, after daily treatment for months.
Let's see if there are any more questions from the
have.
audience.
Right,
Yes, sir.
right here. Are we on? Cool. So I've worked actually in the paratransit space for nearly a decade now, coming up on my 10th anniversary, and specifically working in providing alternative ways to the paratransit passengers to manage their trips, request trips, do the scheduling without talking to a call center agent, which is both slow and very expensive, as you pointed out. And I work with New York City Transit, Boston's MBTA, and they're actually pursuing ride-sharing pilot programs like this primarily for economic reasons. And one of the challenges that we really run into is the adoption of new technologies. And so a question I have for you is the AARP's done some really interesting studies about the adoption of digital technologies, you know, for 50 plus users. And one of the things that we've always bumped into and seem to experience in the real world is that although there are growing numbers of seniors that use smartphones, text messaging and whatnot, their use is actually pretty shallow. So they may have a smartphone, but basically they'll use it to maybe text and go on Facebook. But when it comes to doing transactional things like booking trips and managing things like that, you know, or doing e-commerce or similar stuff, the adoption rate falls off very, very quickly. So the question I have about this particular study, which again I think is really exciting, I want to follow up, is what did you do? Did you feel like you did anything differently, or was there some counterintuitive twist that you used to produce such a high, approval rate? The 90% is pretty impressive. And then the follow-up question is, have these pilot study users continued to use the system over time? And have you seen sort of a growth or decline in that user behavior?
Yeah, so one of the things we did is that we brought in each individual for a one-on-one session for the most part, and we really sat down with them. A lot of people came in wanting to do the call-in service because they don't use their smartphones. Maybe they play Candy Crush, but they're novice, and I encouraged them to try it because we have the support. Our research team provided the support. I said, if you run into issues, you can call us. You can do both. We were like a safety net, and I think that allowed them to try it, and that's why we had such a great success. I mean, we had these, an 89-year-old who just really struggled the first couple times. She didn't think she could get it, and the first time she did it on her own, without me prompting her, with her set of instructions that we gave her step by step, even, something like a back arrow or the done in the top right, things that a lot of us take for granted. We just intuitively know those things. We have to really spell it out. And once they get that confidence, they would just take off with it. So you can kind of sometimes see it would be slow at the beginning, and then every single day they would take it. As for long-term use, so we saw 91% said they would continue using Lyft. When asked why they wouldn't, the majority said cost. So it wasn't even about the technology. It wasn't about the ride service itself. It was about their economic situation.
But you haven't actually been able to measure behavior? That was just an opinion?
Yeah.
Oh,
that
okay.
that was in their exit survey. So we haven't measured anything past the end of the ride.
Oh, okay. No follow-up. So just as a closing, one interesting data point is, so the major providers like Boston and New York, they spend about $50 per ride in terms of direct costs for doing the traditional paratransit van, which is scheduled and a kind of shared ride. And typically the ballpark number for a TNC, a transportation network company ride like a Lyft, is typically in the order of $12 to $16. So the economics are just outstanding. The challenge is just how do you integrate it? And then one other issue is when you have people in wheelchairs or have other sort of disabilities, Americans with Disabilities Act kicks in, and there's all sorts of additional requirements as far as vehicles and training and whatnot. So that's one of the other barriers to widespread adoption of these ride-sharing services.
Definitely.
So let's thank Rebecca Ebert, Paul Irving, and Dr. Paulo Narciso.